with Dr. Lauren Kopicky. She is at the legendary Cleveland Clinic. You know, to be at a facility which has all the latest information, all the latest data, the studies, how does Decision RT, the information, the technology that comes along with that, how does that play into what you do, to really your day-to-day with patients?
Sure. So we're detecting DCIS a lot more often now because our imaging is so good. And so we have a lot of patients with DCIS. Decision RT has been a factor into our treatment decision making as an individualized approach, not putting patients all into the same bucket, and really having that information to really share with patients. Shared decision making is very important, and especially important in oncologic care. So having a test that is so individualized helps to create the best care plan for that particular patient.
Okay, so we always hear about shared decision making, right? To make that truly effective, though, don't you need information?
You do. So patients come with their diagnosis. They come from a place of fear, anxiety. My job is first to educate. So sometimes that means sharing news that isn't easy to hear. The good news with DCIS is I start off that visit saying, this is a stage 0 breast cancer. This is not invasive. This is treatable. Let's talk about it and let's make some decisions. And so I think they may or may not have heard that from the nurse navigator yet. And they've been on the internet. They've talked to their friends. They know somebody with cancer.
I know. It's so dangerous,
yes.
Right?
So too much information can also be challenging. So I think starting off the visit saying, hey, we caught this so early. This is just in the beginning of a cancer diagnosis. This is where we are. Then going over the treatment, standard treatment recommendations, how we can utilize tests like Decision RT to potentially not overtreat, really helps them to feel more comfortable about what aspects we may or may not have control over, but what information is key in making those decisions.
Yeah, so sometimes you have to walk the patients back from this like, oh my God, I have cancer, I want to get a mastectomy, right?
Yes.
Or, you have to really walk them back and say, okay, we have these steps that we can take, and we have to think about this like in a logical way.
Yes.
And when you tell them about Decision RT and they can like literally see the data. Personally, I found it really easy to understand. Has that been your experience?
Yes.
That the radiation oncologists have shared with you?
The report is easy to visualize.
Right.
So for a lot of patients, you're looking at that graph that says this is how I'll do with and without radiation.
Right.
Some similar, so they know they're going to do well even without radiation, but some it's a drastic drop with the radiation. And I think that visual perception, sometimes we get hung up on numbers, but I think just seeing it plainly, it's easy for them to understand.
Well, those kinds of numbers are better than sort of the more vague numbers, right?
Yes.
I mean, you're really getting like data from the individual patient as opposed to playing the numbers game with like the average.
Correct. So when we talk about cancer outcomes, survival outcomes, I say a lot to patients, none of us are promised tomorrow, but this really looks at their individual cancer risk.
Right.
And then how we subject that to surgical treatment with or without radiation. So it really is truly their specific risk. Rather than just historic data of the numbers. Oh, well, radiation decreases that risk in half. Well, not necessarily for every patient.
Not for you necessarily with your genetic makeup, right? Your cells, your everything that makes you you.
And
right?
I think that's in the breast cancer space, women have really found that community and want to share stories. And I tell patients that's great. It's good to have a friend to chat with, but your journey is your own. And one little change in your tumor biology or a test result could mean a drastically different thing between you and your neighbor. And so it's good and bad, just like the information out there.
Well, I think, when you talk about information or lack thereof, obviously you're at one of the premier institutions in the country, right? Let's go outside of that. Let's go into like many, many other places in our country and in the world where they're not aware of Decision RT, or patients are still being treated as sort of a one-size-fits-all. I mean, that is very real. And,
it is.
And what would you ideally like for everyone to know in terms of what's available?
So the interesting part is the majority of breast surgery in the country is done in community settings and maybe not by breast-specific surgeons or those who have undergone specialized training. So I think education of the surgical field in general, we do a lot of outreach into other societies. The American Society of Breast Surgeons is a great way for community surgeons to come and learn about the latest. And so I think hopping on social media platforms, doing interviews and sharing information across spaces that patients access just gets the word out to say, what should I be asking? And there's a lot of great patient resources out there for patients to be knowledgeable, but it is hard if you're in an area where the surgeon's not knowledgeable, the patient's not knowledgeable.
Right.
And we're over or under treating patients, and or I should say inappropriately treating patients, but you don't know what you don't know. So I think it's our job as the specialized breast surgeons to bring awareness to our fellow surgeons in the communities.
Do you feel like the fear and anxiety when the person walks into your office, right, when they've gotten this diagnosis, is that from just, I don't know, Googling around and chatting with people and just not having all the facts?
Yes. So it depends on the institutional protocols of who even notifies the patient it's a breast cancer, how much they share. If it is maybe a radiology nurse navigator, they can't share a lot of information versus if the radiologist has said, even at biopsy, I'm really concerned about this, and this is the typical treatment that we might do, but still you don't know tumor biology. You don't know if it's invasive or not invasive. And so really it's all unknown. And that's where, again, if I can start the visit and say, hey, you do have a breast cancer, but it's stage 0. It's very treatable, curable. There is just that anxiety. You can just see, you hear the sigh of relief.
Yes.
Their shoulders relax. They melt away. There might be some tears of joy and relief because I don't know walking in. I could have looked at their imaging, their path, have a plan already, but I have to meet them where they are.
Yeah.
And so we have to kind of take a step back and say, okay, this is our starting point, because then they can listen to what I'm actually saying versus if I wait till the end of the visit to say, oh yeah, by the way, so I always say that's your take-home message. And when I can give good news, I kind of start, mention it in the middle, mention it at the end. Yeah. If it's not so good news, I might not be able to control the consult in that fashion, but especially for DCIS, it's just a good starting point.
So if you could think of a word to describe Decision RT, what would it be?
Personalized. I think, again, the breast cancer space is great with community and support for breast cancer patients, but you really want your treatment to be very personalized because it's your treatment, it's your cancer, and it's your life we want to get back to.
Should women be asking for this test if their doctor does not suggest it or even provide it?
I think it's one more decision point. And just with any test, it doesn't mean it's necessarily black or white. It's a data point, it's a conversation, and it's that shared decision making. Yeah,
it helps you make a really informed decision.
Absolutely.
Right? Yeah. Great. Well, it's really nice to meet you.
It's great to talk with you, Hannah.
Keep up the great work.